people. Well, this song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo. About our children infected with HIV. Some are orphaned and they don't know what to do. Who will fight for their rights? Who will really care about them? That's why we sing Pata. We care for our children. Whoa, whoa. Whoa, yeah, 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 yeah. Yeah, 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 yeah. Africa we see, Kenya we shout, Tanzania, Mali, Ivory Coast, South Africa, Swaziland, Lesotho, Malawi.
Need medication, protection, and nutrition. No discrimination, but give them the special attention.
Yeah, man.
Future generation.
Welcome, everybody. Good morning, good afternoon, good morning, good morning, good afternoon, and a warm, warm welcome to the launch of the PATA Summit. It's fantastic to be with you this morning. I'm coming to you live from New York, and it's wonderful that we are joining together as part of a global community. My name is Shafiq Isaji, and I'm the Senior Advisor on HIV at UNICEF. And I've been a member of the PATA family for over 20 years. So it's a real privilege and a pleasure to welcome you to this morning's summit. The theme of this summit is breakthrough. And how we can build back together. And this is something that we've all been grappling with. We've missed our global targets for 2020. This was the year when we were going to bring an end to pediatric AIDS, but instead we've gone backwards because of COVID. So how are we going to reach our goals and rebuild services for children and adolescents, especially when we've suffered so many setbacks and shifting health priorities due to COVID? This has been an exceptional year for so many reasons. And for the first time in 15 years, we're not all together as a PATA family at the summit. The summits have been the heart and soul of PATA. In fact, the meaning of PATA is to reach out and touch, which is something that we can't do right now. We have to reach out to each other virtually. It is indeed disappointing that we can't meet together. And for many of us, the PATA Summit is a highlight in our year, and coming together as frontline health workers, meeting our colleagues is a source of great revitalization for us. But I'm hoping that we have found a way to still get that energy, to still be able to reach out to you in these challenging times. And in many ways, now, through virtual means, we can reach many more frontline providers than we could if we were meeting in person. As many of you know, this is a unique setup that we're trying here at PATA. And while we are all connected virtually, we are also in 10 countries and applying safety measures as an organization. So we have 25 satellite in-country mini summits. These are groups of people that have gathered to participate in the summit in small satellite groups. And this is really quite a feat. The first time we've done this and creating a platform for PATA to expand its ability to reach and engage and provide access to the frontline providers not just in this year's summit, but beyond, creating a community of caring and sharing that we can all participate in and get value and benefit from. Now, this first session this morning is entitled Wake Up, Close the Gap for Children and Adolescents. And I know our panel of speakers are going to put a lot of context to this to set the scene and provide a really important reality check for the remainder of the summit. And we're privileged to have an excellent lineup of presenters, each distinguished and most importantly, all of them activists and strong voices for children and young people. I'm going to introduce all of the speakers up front, and I'll just provide a brief introduction as all of their bios and details can be accessed through the virtual hub. So the panelists are all going to be with us today, other than Dr. Mofokeng, who's sadly unable to join us in person, but we're thankful for her video address and her special message to all of us. So we're going to kick off by asking Lou Hatan, who's the director of PATA, to provide a quick overview of the summit and give us an idea of what to expect. And I hope that she may also be able to connect us virtually to some of the in-country spokes, these 25 gatherings of PATA family who are in different parts of Africa. Following Lou's address, we'll have Dr. Martina Penazzato, who is the pediatric lead for HIV, hepatitis, and STIs at the WHO, who's going to offer us a bit of a reality check on the progress and setbacks that we've had from children and adolescents in the HIV response over this past year. And following that, we have a keynote address from Dr. Tlaleng Mofokeng, known to many as Dr. T. Dr. T is a South African medical doctor, an activist and author who currently serves as the UN Special Rapporteur on the right to health. Our last presenter in this opening session is Lois Chingandu, who's the Director of Evidence and Influence at Frontline AIDS. Lois will importantly raise the COVID alarm for children and will highlight the impacts that this has had on service delivery and funding. I'll be back with you later, but for now, over to you, Luann.
Great, thanks so much, Shafiq. And yes, warm welcome to everyone. And it's just so marvelous being here with everyone. And yes, as Shafiq was saying, quite a different summit this year, but hopefully going to be as valuable and as enjoyable as all of our other summits. As Shafiq was already mentioning, I mean, we know that the theme for this year's summit is breaking through and building back together. And you will be able to see throughout the program that you can all access online in both Portuguese and French and English. You will see that many of the sessions are really all focused on strategies, tools, and comprehensive service delivery models, really trying to accelerate HIV case finding, linkage, and access to treatment for children and young people. Of course, we hope that this platform will continue to still try and build partnerships and link us, even if it has to do so virtually. And of course, there's no way that we could have a summit this year without really thinking about the impacts of COVID and what setbacks that has created. The other real focus of our summit this year is really importantly that of frontline health providers. And I think you would all agree with me that there has been no other year like this year to really demonstrate and highlight the very real inequities that many health providers are facing, and the real fragility of our health systems. So I think for many of us, you know, we talk about safeguarding the rights and dignity of children and young people, which are extremely important. But for us at PATA, you know, importantly is also how we better safeguard those who deliver services. So really, what are we doing to provide better working conditions for those on the front line? As Shafiq has already shared with you, we are all connected in different ways. We're trying to be really creative this year And our new normal has really meant that we have to do something differently. So in terms of this virtual hub where many of us, me like you, we are all connecting, but right now across our region, we have many, many people who are meeting together physically and are also connected to this virtual space. We have the 4 main spokes where, you know, many of our countries are having morning mini summits, so in-country meetings. And then in more than 10 countries, we also have many, many people coming together right now who we're not going to see virtually because they're all connected to one virtual connection. But this is many, you know, frontline providers sitting in a clinic or sitting at a community-based organization who are all with us today connected in this space. So just in terms of numbers, in terms of people registered, we can get a sense that we're hoping to have close to more than 900 participants. And as Shafiq was saying, this would be a real important lesson for us in terms of being able to reach many, many more people than normally we are able to in a Pata Summit. And you could see that we have about 300 people who've been registered just to be on this virtual space. But many, many more people who are actually sitting in a physical space at one of the satellite or main spokes. So in terms of registration, we have over 112 facilities registered across 27 countries. And you can see in terms of treatments, you know, these 112 facilities are providing treatment to over 600,000 people living with HIV on treatment. Worryingly, of course, and something that we always see and know is the very low number of children that we continue to reach, and also challenging that some of our adolescent numbers are somewhere between both of those figures. Just in terms of the structure of the summit, essentially anyone who's been to a Pata Summit, it will follow a very similar structure. So there would always be sort of an opening or prime session, and then you have a choice of 2 Africa cafes, and then the last session of the day is a special session. And there are different language options available in each of those sessions. So please do check with your program. And then, of course, just really encouraging you all to please keep Twitter and Facebook. I've been watching, it's been really quite incredible, the kind of buzz that's going on social media. And I think we can definitely thank lots of young people. I've seen many in Zambia, Uganda, Zimbabwe, really doing amazing things. So thank you. And then please to access the virtual hub. This is a way where we can connect, and we're hoping that all of our spokes are actually connected via this virtual hub through the session links, where you can access your sessions, but also where you can connect with one another, and please post things on the activity wall, etc. And what I really did want to do now was we were hoping to connect with some of the spokes so that we could say hello to you. And I'm not sure, the only person I think who might actually be here is Eddie from Eswatini. So Eddie, if you are there, if you're able to unmute yourself and put your camera on for 1 minute, just so that we could wave, that would be lovely. But I'm going to count on 3, and if we see you, that's great. If not, we're going to just move on. Yay! Hello, Eswatini. Great, thank you. So good to see you all. Wonderful. Thank you, thank you. I'm going to quickly just share my screen again. Incredible support from our many funders. Really a huge thank you to all of our funders. And then really just the last point, I'd like to acknowledge and dedicate this year's summit in memory of Mangaliso Dludadli, passed away last week. Reddy family in Eswatini. So really, let's hold his memory close to us, and let this be a reminder that despite having the tools, the treatment, our battle truly does still continue. And with every death is one too many. So as frontline health providers and youth serving organizations, we have a responsibility to change this. And on this sobering note, I think it's apt that we move on to our first presentation, which really does provide this reality check on the progress and setbacks in the HIV response for children and adolescents. Thank you so much.
Thank you so much to Pata for the invitation to contribute to this important summit in a year when we're actually acknowledging and reflecting on the role of nurses in the response to HIV. Today, I'm going to share a few thoughts about how we can all contribute in our individual capacity to really ensure that children living with HIV receives the care that they need. And I'm sure that many of you have heard already how much progress has been made over the last few years in preventing vertical transmission. And you've contributed to that by initiating ART in pregnant women. And we know that there's a number of countries that have already certified the elimination of vertical transmission. And there's a number of sub-Saharan Africa that are African countries that are considering plans on how to get there. Now, we know that sometimes this progress, which is really important, has been interpreted as there's nothing else to be done for pediatric HIV, and that it's probably just a matter of time until we get to a generation where no children are born with HIV. But when we hear that, I think it's important that we challenge that perspective, and we really challenge the acceptance that at times the global community has with lower standards for the care of children and adolescents living with HIV. And it's important that we ask ourselves, why is it okay that 40% of all infants exposed to HIV are not receiving an HIV test in the first 2 months of life, when we know that disease progression is so fast in just children? And why is it fine that only half of the 1.8 million children living with HIV are receiving antiretroviral therapy? And in some places, even if they do so, only 1 in 3 is actually reaching virological suppression. And we know that unfortunately, this is not getting better this year. Why? Well, because we all know that we are in the middle of a pandemic that is exposing a lot of the weaknesses that we already had in our system, and is adding a few more challenges. You, in your own experience, in your everyday life, can observe that the past 6 months have been really challenging because mothers and children have not come to the facility as much. And even when measures were lifted, they struggled and they were scared to come back to the facility for the concern of being exposed to COVID. As a result, as you know, you haven't been able to identify and start on treatment mothers and children the same way you would do normally. And we know that there's been a number of challenges with ARD stockouts that have been reported at the time when you were actually making important efforts to improve the regimen and the formulations that you were providing to children. So while it's still unclear the impact that COVID-19 will have on the HIV epidemic, particularly for children, I think it's fair to assume, based on some of the modeling work that colleagues have done, that we can expect a higher number of infections in children, which may actually take us back to where we were 5 years ago in terms of vertical transmission. So it's very clear that it's really not a matter of time, but it's a matter of action, and that we can't wait for the next 10 years and wait for an AIDS-free generation to come by itself, but we need to act now, doing the things that we know that work. And we also need to be able to use the experience and the data that we are collecting to fully inform the way we deliver these interventions, and then start to plan for the future and think about how we can develop new technologies to better diagnose and treat children and adolescents that live with HIV. So starting from what we can do now and what you can do now, to ensure that those interventions that we know work can be implemented more systematically and more widely. So one example of those is certainly diagnosing children where they acquire infection in the family through index case testing and family-based testing. These data is data presented in July at the AIDS conference by Hilary Wolf and colleagues that showed implementation of index case testing on a number of PEPFAR-supported programs. And from their data, you can see that if you actually implement index case testing well, you can identify children that would otherwise be missed. So it's very critical that we really systematically test all the children of a mother or a father that is right in front of you and that is living with HIV. Because these interventions, it's fairly straightforward to be done, and you know how to do it because you do it very frequently in your work. And it's important that we just systematically implement it more widely. We also know that we have more technologies available to us now. We know that, for example, we have technologies to undertake infant diagnosis much more quickly so that we can shorten the time for treatment initiation in infants. And we have a lot of data that shows how these technologies can have an impact. However, we know that these technologies cannot be implemented in isolations, and they need to be provided with a full package of services that, that really improve and address the vulnerabilities of children in general, but in particular of those little ones that we often struggle to treat. I think that today we are a bit step closer to being able to provide better care to infants and children. And that's because in July, we had approval of dolutegravir from 4 weeks and 3 kilos, which now allows us to really implement WHO guidelines, which already recommend Abacavir 3TC dolutegravir as the preferred regimen for all children above 4 weeks of age. Thanks to the approval that the US FDA has given to dolutegravir, we also have clear dosing recommendation coming from WHO that really allow use of dolutegravir between 3 and 20 kilos. We also know that we are awaiting approval of generic formulations of dolutegravir as a 10 milligrams core dispersible tablets with good taste. And we know that these formulations are expected to arrive in countries in Q2 next year. We also know that we have another formulation that is going to be critical to us, the 4-in-1, that will be used as an important alternative for those children that will not tolerate dolutegravir or that may not have access to it. But it's clear that introduction of these products needs to happen with the support of many of us. We know that many of you have faced tremendous challenges in the past with introducing new formulation. We know that you've been often frustrated and really disappointed for not being able to actually have it in your hands, the formulations that you wanted to provide to children that you knew were going to be more effective. But we know that to avoid those important delays that we observed in the past, we have to start to work now. We need to join forces and develop plans at a country level to be able to anticipate the work that needs to happen and be ready once this formulation will hit the ground, to be able to take it to the patients that most need it. We also know it's not just about delivering antiretrovirals, but we know that there are some of these children that still present with severe immunosuppression, and these children need more. These children with advanced HIV disease needs to be screened for opportunistic infection, needs to be treated for those if infected, and needs to be provided with optimal care as well as preventive interventions that can protect them from any other opportunistic infection. We know this is a difficult one to do, but it's really about time that we stop AIDS in these children. And this really requires a lot of our focus in the next months to come. We also know that it's not just about identifying children, starting them on treatment and controlling the virus. It's also about what we call the fourth 90, and it's reaching that health and well-being that children need to reach their full potential. And that entails screening for developmental delays, providing nurturing care with very simple intervention that can be provided when patients are right there in front of you and just waiting for their visits in the clinic, or even the community with very simple things that can be provided easily. We also need to work more on nutrition and be able to identify those disabilities that we know affect the quality of life of children. And finally, mental health issues that we know are a particular challenge for adolescents that have lived their entire life with HIV. So it's really important that we place this longer term vision to the health of these children and that we think about it in a much more comprehensive way. As many of you know very well, often the way we deliver intervention is as important as the intervention itself. And this is where we really need to learn from the experience on the ground to be able to better tailor the way we deliver services to children and adolescents. And there is a very good example provided by the work that Giandiri has done in exploring the impact that peer support can have in improving outcomes for adolescents. And we know that this model, the CATS model, as well as the READY+ work, it's currently being adapted and adopted in many, many countries and really helping us to provide better care to adolescents living with HIV. And so it's very clear that we need to find new ways to deliver interventions to children and adolescents. And COVID is an opportunity for us to probably identify those approaches that can be effective even in a time of crisis like the one of COVID. For example, many of you have been in the situation of providing to children and adolescents with their drugs for multiple months. And this is something that perhaps we've been reluctant to do in the past because we were concerned that children and adolescents would require more frequent visits. But actually, COVID is forcing us to do and implement this approach. And we are seeing that actually this is in some cases where children are stable and healthy, can really improve their quality of life. And this is something that we can preserve for the future. We also know that many of you have used the digital tools to reach the patients, to provide information or to provide support. And we know that some of these tools are not widely available everywhere, but we know that they can be an important addition to the tools that we have available to really take care of children and adolescents in the most effective way in the future. We know that it's important that we really document all of this because the experience that you all are having in your own country and in your context is critical to be able to tailor this intervention to the epidemic context. It's important that we think about new solutions and test them in multiple settings because what is right today might not be right tomorrow. And we have to keep monitoring the way we do things and collect data so that we can use them to inform the way we deliver interventions and where we deliver them. So it's really, I want to emphasize how you can really better use the data that you're already generating in the facility, and that data can really help you to better tailor your own work. We also know that we can work today to improve the future of tomorrow, and it's really through developing innovation and new tools that helps us to diagnose and treat children better. For example, there's a number of technologies that are in the pipeline and then can really help us to administer drugs in a better way for children. Some of these technologies already exist and they just need to be investigated and applied more. Others still require some work because they need to be better studied and better developed. But the key point here is that we all need to contribute to this process. And a partnership is really a critical point for the Global Accelerator for Pediatric Formulation, which is a WHO network that we've set up with our partners to accelerate the investigation, development, introduction, and rollout of better medicines for children across disease areas. And it's really exciting to have PATA as a key partner of this adventure, because we know that we really need your help to understand what are the characteristics that these new formulations should have to ensure that they're easy to use by the caretaker and by the healthcare worker. And we also want you to work with us to ensure that we can take these formulations faster to the ground. So we're really excited and look forward to work with all of you in the next future on this issue. So to conclude, I really want to emphasize how important it is that we all work together in our own capacity and in our own roles to act now and really implement those interventions that we know that work. And all of you are on the ground, can be really the engine of the change that needs to happen. And we want to make sure that you are supported and there's many stakeholders around you that can be of assistance and are really there to be helpful. We also need to do a better job at collecting experiences and data and be able to use it to inform the way you deliver the interventions. And finally, to work together to think about the future and how we can develop better tools to diagnose and treat children living with HIV. So I really hope that we don't let COVID-19 stop our progress. We need to use this opportunity to almost bounce forward and really build back better, as they say. We know that none of this can happen without the frontline workers. So we truly need your support, and we can, if we work all together, get to an AIDS-free generation. Thank you very much for your attention.
Good afternoon, colleagues. My name is Dr. Tlaleng Mofokeng, and I'm the United Nations Special Rapporteur on the Right to Health. I'm also a commissioner at the Commission for Gender Equality in South Africa and National Human Rights Institution. And of course, I am a medical doctor that used to be in practice, but not so much anymore. I am an activist, a medical doctor who is also a human rights defender. And I'm quite honored to be able to join you as you launch and celebrate PATA 2020 Summit. And your theme really is so important: breakthrough and build back together. And we know how important building has been this year because we have been broken, so many of us, by this COVID-19 pandemic. But this is a moment in time that we can create the space and a moment to visualize what a better world would look like post-COVID, during COVID, and hoping that many of us who are essential services workers, such as yourself as healthcare providers, remain well and healthy and are able to offer quality services. I'll be talking to you today, of course, as a health provider myself. We are rights activators and activists in delivering stigma-free, child and youth-friendly services. And in my younger years, I'm not so young anymore, but in medical school, as part of my family medicine project, I went to a rural town in the Eastern Cape and actually set up a youth-friendly clinic. At that time, we were called Groundbreakers, and I had, mobilized some resources and some merchandise to be delivered at the clinic. And it was so important for myself as a young woman at the time who was needing stigma-free quality services around my own sexual and reproductive health needs to make sure that other young people are equally served quality services, are given information that enables them to make best decisions for their lives, and that regardless of what their life ends up turning out like or whatever challenge ends up, confronting them, that the health system remains a place of safety that does not take into account your age, your class, your gender, your geography, or to even, decide who's worthy of dignity and quality service. And so it's always been my vision, to work in sexual and reproductive health, because I know that if I can make a difference to one person's life in that particular area of their life, especially a young person, I know what it means for their potential, for themselves, but also for their life. It's so important to talk about the fact that, a successful HIV services and treatment programs and those positive health outcomes rely on accessing stigma-free, comprehensive sexual and reproductive health and rights services. This requires healthcare providers who are open and willing to acknowledge the rights of young people's bodily autonomy, sexual exploration, and decision making. It is so important as healthcare providers to understand that the manner in which we practice medicine, the manner in which we practice nursing, the manner in which we engage with our patients, with our clients as we give them services around their health, can often promote, protect, and advance their human rights. And it's so important that regardless of someone's age, whether they're a young person, whether they're a child, an adolescent young woman, it doesn't matter. All of these people deserve their rights, deserve dignity, privacy, confidentiality, so that they can trust us as healthcare providers with all of their challenges, so that they can be vulnerable to us, right? Because we are asking people to trust us with some of their most vulnerable moments. And for them to be able to do that, they need to know that we'll treat their information with confidentiality and privacy. And of course, that will enhance firstly the types of consultations that we'll have, but also how our patients then seek help in future. What's also important is that I know also, right, I was a young medical student, a young doctor, but even I found it difficult sometimes to speak to my colleagues who were a bit older than me, even about sex and sexuality as a medical provider. So can you imagine the difficulties that some older healthcare providers may face? Because a lot of young people may be asking questions that you are not ready to answer, maybe asking you questions that perhaps the answers you've never even imagined that anyone would ask you that. And many of us in medical school, in nursing school, even in allied health colleges, right, we are not really taught properly about human rights, about sexual and reproductive health, about SRHR rights, and many of us are getting challenged by our patients in the field in the moment. So don't be shy, don't be nervous to say when you are not certain. Rather be honest with your patient and say, I'm actually not sure, but let me find out for you, and make sure that we are giving our patients information that is credible, that is evidence-based. Of course, a lot of your members at PATA come from very, very different countries that still criminalizes HIV transmission, that still criminalizes abortion, that criminalizes same-sex relations and marriage, right? And we know that even if issues are not criminalized, the stigma, right, can actually perpetuate and create an environment where young people feel disempowered, despite the fact that the legal framework is not one that criminalizes them, but the stigma and the discrimination and the prejudice can often make young people feel unwelcome. And we know that young people become more vulnerable because of the situations that they find themselves with, and are more at risk, right? We know that especially adolescent young girls are recognized as a population group that's at risk, and they are often unable to access services they need. They feel unsafe asking for advice and support from a healthcare provider. And it's our role to understand that the right to information is a human right. The right to autonomy is a human right. The right to bodily integrity is a human right, and that all these human rights are interconnected to lead to positive health outcomes, to lead to communities, to societies, to countries, right, to populations, and most importantly to individuals who are affirmed. And they are affirmed by how we treat them. They are affirmed by the type of services and the quality services that we provide. So it's my hope today, as you rebuild and as you build together, you envision a future where regardless of who you are, where you are born, what gender you are, what sexual orientation you are, who you love, and how you have sex does not lead to discrimination or prejudice. And that in fact, our humanity is respected, and that our dignity is restored in how we engage with our patients. Congratulations on this amazing summit. I look forward to learning from many of you in the few years and the months ahead as you support me in my new role as the United Nations Special Rapporteur. And I'm really encouraged and privileged to have had this time just to share these few words with you. And as you go ahead with your summit, as you engage and share and learn, let's remember to keep an open mind and just honestly hold each other and create that space peace, as all of us are trying to survive this pandemic and come out through the other side in one piece. And with that, I would like to wish you well and thank you very much to the PATA team for inviting me to this session. And so with that, I would like to say good morning, good afternoon, good evening from wherever you are joining in the world. It's Dr. Tlaleng Mofokeng. Goodbye.
I am going to be looking at how COVID-19 has impacted on children and adolescents, and also what the funding scan is looking like right now, and what we should be thinking about going forward as NGOs working in this sector. My presentation is formatted. I will start with an introduction. I will talk about the impact of COVID on children and adolescents. I will talk about the innovative responses for NGOs. I will look at the funding scan, and then I will end with what can NGOs do. 7% of the 12 million children have suffered from COVID-19, and that leaves a huge percentage of children who have not necessarily been infected with COVID, but have suffered negatively from the impacts, particularly socio-economic impacts and control measures put in place by government. When it kept going week after week after week, we saw a lot of children getting restless, getting impatient, getting distressed, and they began to become angry, anxious, and some kids even got depressed, and some did self-harm and in some cases, suicides. Many of you know the story in South Africa. There's a man whose son committed suicide at the age of 13, and he specifically said, I blame COVID-19 lockdown for the death of my son. We also see different impacts in other areas, eating disorders. The online school was not necessarily suitable for every child, and children were just stuck in the house, fighting with parents, more housework. When you talk to many children, they do complain about this. And the feeling that they explain was feeling that they had nowhere to escape. It's important for us to also look at children with disabilities and unique challenges, because over and above all the challenges I mentioned earlier, those children had another layer of challenges. Those with physical disabilities stuck with caregivers or parents who themselves were already stressed and anxious, and many of them did experience abuse, in the emotional abuse and physical abuse. And for children with autism and children with ADHD, whom we know already need space and activity, they tended to be more anxious and also presented with more mental health challenges. In the economic impact area, it's important for us to note that multi-dimensional poverty was worsened by COVID as breadwinners lost jobs overnight. And this was multi-dimensional in all the areas. Millions of households were pushed into economic despair because it was overnight. One day, mom had a job and we had food, and the following day, there were cuts everywhere. And according to an assessment by UNICEF, with COVID, the situation for children living in multidimensional poverty is estimated to be 56%. Impact on education is also an important area for us to look at. Even though many schools tried alternative forms of learning, such as online schools, web-based courses, homeschooling, most of these were inaccessible to children in low and medium income countries. Up to about 1.6 billion children worldwide have been affected by school closures, and because many of them have no access to internet. And even those that had a little bit of access to internet, with the parents not working, nobody could pay for that, for those services. There were also challenges around the mere threat to child survival, which is access of children to life-saving vaccines. And approximately 80 million children under the age of 1 in at least 68 countries could have missed out on life-saving vaccines. In nutrition, we know that agriculture sectors were severely impacted. As many as 132 million children may go hungry in 2020. Of that, 36 million due to the fact that the agriculture sector was severely impacted. The whole food chain process was disrupted, which is now threatening food security and is causing malnutrition. Decades of progress that we made in HIV is also a huge issue. The service disruptions that we saw, the delays in supply chain of essential drugs and materials, the resources for HIV which were diverted to COVID-19, and at least 15% of pregnant women and close to 50% of children and adolescents who are not on life-saving HIV treatment. We know that they have a higher risk of contracting COVID-19 because they are already immune compromised. There were also risks around child safety and unhealthy home environments. Child labor became a significant issue. Many of you know that most homes had to let go of house helpers, even here in Africa, because of the risk of COVID-19. So most of the children had to assume housework. Children also during that time, because of being at home for so many hours with frustrated parents, some of them witnessed and suffered violence in the homes. I would like to really quote Finn Tapp, who is a professor of development economics at the University of Copenhagen, who said, "For the world's poorest people, each day is a crisis of finding work, enough to eat, and safety. And theirs is an ongoing and continuing crisis." And I don't think there's a better way of describing what happened with COVID-19. I also looked at the impact on institutions like NGOs. I think it's correct for us to acknowledge that COVID-19 also exposed weaknesses within the NGOs, particularly lack of preparedness for emergencies. There was lack of unrestricted resources to provide flexibility needed to respond to eventualities. You know, most NGOs work with shoestring budgets, very fixed term, fixed on what to spend them on. And once there was this crisis, they had to take a lot of time going back to the donors to renegotiate. And a lot of time that could have been used to serve clients was used in that process. Many NGOs didn't have the digital systems that were needed to quickly shift to remote working and to keep programs running. And it took a bit of time for many to really re-establish themselves because they just didn't have the kind of digital systems that were required, and no access to protective clothing and equipment to enable them to go into the communities. And most NGOs are just as poor as the communities that they serve. And sometimes they had to also immediately lay off staff. Right now, many are anxious regarding their own sustainability as organizations. Having said that, it's important for me to mention that there were a lot of NGOs that stepped up. And as Frontline AIDS and our partners, we did document our partners who really stepped up to the plate. We ourselves did give out a rapid response fund grant, which we distributed in record time. We also gave what was called a partnership fund. The partnership fund was to support partners to buy things like computers, to set up Zoom systems, those things which I talked about earlier, which they didn't have. And we did this in about 37 countries across Africa and the Caribbean to allow them to respond to the needs of key populations. And I'm very proud of ourselves because of that flexibility. Let me switch gears a bit and look at what was happening on the funding, in the funding arena when all this was taking place. As you note in that figure, you see that overall commitments from key bilateral donors were 24.5%, which is 9.3 billion lower over the first 7 months of 2020 when you compare with 2019. It's indeed increased around June, and most of that money was going to support organizations to respond to COVID-19. This slide also shows us what the multilateral donors did. The multilateral donors actually increased their contribution higher than in the first 7 months of 2020. You will see a very interesting scenario, which is the bilateral donors. They were giving money to multilateral donors because on the multilateral donors, you have the UN family listed there. And so most of the monies went to the multilateral UN family structures, and then it was dispersed down the chain. When you look, you also see that in the first 7 months of 2020, commitments to health increased significantly by 80.6% to a total of 14 billion compared to previous contributions. And this should ideally be good news. But when you look intimately to see what the money supported, you will see the bulk of the money did support COVID-19, and some of it went to research, some of it went to supporting the vaccines, and some of it supported governments to respond to COVID-19. And you see that significant spike in June. So there was general increase in June, and the monies went down again after June. The bond result, bond is the network of NGOs in the UK who did a survey after DFID announced that they were going to reduce and cut completely they did immediate cuts of funding for what they called non-essential services. And the network did a quick survey to look at the impact of what that is going to be on NGOs. And some of the results are really sad, but a reality of what is facing the NGOs in the coming few years. I thought it would be pertinent for me to just flash some of the headlines that we are seeing on the donor tracker. And I just pulled a few, but if you go onto the donor tracker, just 1 month of October 2020 to see related projects. And within that is the vaccines that are dominating. A lot of these governments have already prepaid for vaccines that are under development, starting from the US, the UK, all of them have already put money up front for vaccines. The issue of vaccines becomes critical, particularly for Africa, because if that happens, that all these countries have pre-booked vaccines, this is why it's very important for many of you in this conference to really pay attention and join the campaign on the People's Vaccine, in which we are calling that the vaccine must not be patented and it must be distributed fairly around the globe and not just for the countries that have money. This slide is again part of the donor tracker, and I put it there again as an example for people to really see where the money is going. It's very important that we understand this, because when I'm going to talk later and I talk about what we need to do as HIV NGOs, we need to be aware of how things are shifting. And even though when you look at health budgets, they will look like health budgets increased significantly, but none of that money really went to HIV. So what can NGOs do? The first thing is that we need to recognize the phases of the pandemic and respond accordingly. We started with the emergency phase, where we were firefighting, prevention and mitigation, and we put in place all these mechanisms. We now need to enter a predictable phase where we now know more about prevention, we know more about the impact, and we need to position ourselves to respond to the predictable phase. And we also need to start thinking about the future, which at the moment it's unknown because of too many variables. The end of the pandemic, the vaccines, the resurgence of infections, all this is just bubbling up in the pot. And I called that period that we are trying to think about, the VUCA period: volatility, uncertainty, complexity, and ambiguity. And my message is that we need to accept that this is just what it is, and we make peace with that. And then we have to strategize to respond across the 3 time zones, which is the now, the next, and the beyond. The now is the immediate actions that we need to take. And I think we are doing that. Then the next is the stabilization and developing resilience for communities and also for ourselves as NGOs. And then we have to look at the long term, which is everyone calls it the new normal. We need to start defining what that new normal means and what it will mean for NGOs. One of the things she said is the pandemic has called into question so many aspects of the world that seemed permanent. Our social behavior, our modes of governing, our financial institutions, our travel patterns, consumption habits, and healthcare systems. While the world is still grappling with the agents of controlling the spread of HIV, the aftermath will create a second wave of systemic disruptions, likely bigger than the first. One system to be looked closely at is the Western neoliberal model of development aid that has dominated since the post-World War II era. And out of that, we draw the lessons that we learned from the crisis. We learned the limitations of the current development model that has grown so large over the last 30 years, and must accept that we can no longer afford, or literally or morally, to rely on the current approach to development with its reliance on a steady supply of external goods and services. Because during COVID-19, all of us exited the communities when it mattered most, because at that time, what was important, it was our own well-being, and we left. And in the end, the communities showed that they are the most important players, because when push comes to shove, local capacity is what matters most. This is how we need to measure development effectiveness. How did the communities cope when we left the villages? And this should be the end goal for the industry to return to. And the question now is whether they will be pushed or pulled to do so. Is civil society engaged in this discussion where the shifts are being called for? The pandemic calls for a major rethink of what sustainable development actually means. It's time for development aid industry to also change like everybody else. Non-essential, non-empowering development assistance needs to be reevaluated. Non-sustainable models of funding, such as short-term funding for a process that needs years of transformation, doesn't really help anyone and needs to be really looked into. What is civil society opinion on what development aid should look like post-COVID? I believe civil society must be part of this discussion, and pushing for development reforms. And what will those reforms look like? Civil society reforms are needed as well, because the development models that we've been implementing, some of them have been creating dependence rather than independence of the community. Staffing of NGOs must prioritize locals who remain in the community and continue to work way after the crisis is gone. Are we able to be true to what we believe and respond to the true needs of the community? Whose agenda is it anyway? And the gap-filling role of CSOs needs to be redefined and reevaluated. Have we become quasi-government structures and therefore need to exist there forever, shifting our focus with each funding cycle? Is that really what we should be doing? The reality is that we are not going to have the kind of funds that we've had in the past 3 years, 2 years, 5 years. I think that era is almost gone. We have to be real that the money is going to be less. What are we going to do with less money? Because the work still needs to be done. We must be thinking of a triangle, a smaller HQ, and with most of the people distributed within the communities that we work in. We must rethink travel. Today, I'm doing a presentation that I should have traveled for hours to go and make this presentation. But, because of the circumstances, I'm doing this presentation, and it's working, and we need to be okay with that. We must rethink the services that we are offering. Can they be offered by government and communities? Do they need us to be physically there in order for things to happen? Can we equip, retool, and capacitate communities to become future development entities? Do we need to be in every community? Are there no communities that we can say in the last 30 years we've capacitated and they don't need us anymore? And if they still need us, then it is raising a real question regarding our own methodologies. So in conclusion, I just want to say, COVID-19 is not a blip in our lives. It's changing everyone. We need to change with it, or we will be forced to change, because change is inevitable. The only organizations that are going to survive this are those who seek to define their own future direction, manage the process, rather than to be pushed by the winds of change. I thank you.
Well, welcome back, colleagues. I'm now pleased to host the live Q&A part of this session. And I'm going to ask all the panelists and presenters to please turn their videos on as well. What an incredible start to this summit. Great presentations, great information presented, and so many important points already raised, barriers to overcome, and some tangible recommendations given. Many of the questions are in the Q&A and have already been answered, and I would encourage all of you to read through the answered questions if there's something that you wanted to see the response to. But I'm going to just kick us off by asking a couple of questions of both Lois and Martina. Martina, you told us very eloquently about the fourth 90. Can you share with us the extent to which this concept has been taken up by the broader community? If our colleagues listening in were to go to their ministry partners and said, what about the fourth 90? How can we help to achieve this? How much traction has this language already developed around what the concept of the fourth 90 is? Martina, over to you.
Thank you, Shafiq, for that question, and for other colleagues that raised that point on the chat box. I think that, there is so much that we still need to do on identifying, treating, and reaching virological suppression in children and adolescents, that I think that the biggest attention has still been on those. And so I think it's fair to say that what we call the fourth 90 hasn't really made it to the top of the list, if you like, of what countries are really currently focusing on. And I feel like partly is also because perhaps we haven't even started to monitor any of that. And we know that that's often a sort of incentive and a good prompt for countries and programs to really be able to better acknowledge that problem and be able to respond to that. I feel like that doesn't mean that nothing has happened on that. I think that many of you that provide care to children and adolescents in general know that survive, thrive, and transform is really a key framework for all of us that are involved in providing care to children and adolescents. And so in that sense, there are interventions that are already in place in countries. They are typically provided through other entry points or through other platforms outside of the HIV program. And so perhaps the question is less about can we start doing something more, but it's more about how do we effectively connect the HIV program and the activities that the HIV services in the facilities with everything that is already happening in that facility that already provide support to nutrition, for example, or interventions to ensure that there is nurturing care and early childhood development interventions, which we know are being picked up by countries. They might just not be in the HIV clinic. And so I think that this is a good reminder that to implement the fourth 90 and to really take it seriously, we really have to work with our colleagues that are more focused on maternal and child health services in general, and see how we can synergize and maybe divide and conquer. Because we know that already there's so much that you have to do in your everyday work in the clinic that you might not be able to undertake all of that. But even just being aware of it and being able to refer patients to the right colleague would be a really important step.
Martina, thank you very much. Lois, thank you for your wonderful presentation and the great information that you provided. And you know, just wanted to commend Frontline Aids for mobilizing so quickly to give the emergency funding that NGOs needed. There's a couple of questions that are coming up in the chat that I wonder if you could help us with. Given that COVID-19 is still upon us, what is your advice to staff who are at the front line, who are already grappling with meeting their service demands and now have to grapple not only with that issue, but also with the question of their own lives being placed at risk as countries experience second surges and new waves of COVID-19 infection? How can we adapt to be able to cope with this new reality? Lois, over to you.
Thank you so much, Shafiq. The question you're asking is a very challenging question that everybody is trying to grapple with. And that's why in my presentation, I spoke of the need for us to respond to the now and the beyond and the future. You know, it's all in one. We no longer have the luxury of the past where we would say, this is the issue we are dealing with. We are going to address this. When it comes to an end, then we will plan for the future. We can't do that. We actually have to think about everything all in one. We can see from the Western countries that the reality of a second wave it's coming, and we know it's going to come. What we can do for ourselves is we have had the advantage, for example, in Africa, we have the advantage of some notice period, I could say. So we should be planning better instead of waiting to have another emergency. There will be no excuse for us to say we have another emergency. We know what needs to be done. We know we need to have protective equipment right up to the grassroots level. We know we need to enhance the education. I can see, and I'm sure many of us can see now, that the people are starting to relax. And also even the government messaging is starting to relax. We cannot afford to do that. We should be increasing the messaging so that people understand that it's not over. You know, if we just relax, we allow this virus to come back. And when it comes back, then we have another emergency. Then we are in the cycle again, and we cannot allow ourselves to keep going back into that cycle. We do need real leadership in the era where we are, not just government leadership. We need leadership at all levels. And I'm talking about at the NGO sector, but I'm also talking about in the donor sector. We do need leadership that genuinely sees that this is a problem that is we are in, and it's not going to go away in a long time. And so at the moment, we are all sitting with anxieties of not knowing. The feedback we hear from the donors is that they are all discussing internally what the impact of this is going to be on the resources that we're going to organizations, let alone for HIV. That for some reason, the message needs to come back. The answer needs to come back. Is there going to be resources or not? Is there going to be a reduction or not? And yes, the NGOs need to do what I have spoken about in my presentation, where we can't sit and hope that business as usual. It's not going to be business as usual. We have to be more proactive in looking at where do we cut down our costs? How do we behave differently? How do we empower communities so that when the second wave comes, the community is not waiting for us. The community is ready because they know what to do. They have the equipment, they have the knowledge, and they have the resources.
Lois, based on your experiences, do you feel that the relationships between NGOs and government is shifting as a result of COVID? You know, historically, They're called NGOs because they're non-governmental. They're this other thing. But I think COVID has taught us how critical those community response organizations, how the NGO community can mobilize and respond in ways that are different to government and complementary and so critical. Do you see that relationship shifting, and could that translate into funding from government to NGOs as opposed to the donor community funding NGO work?
Yes, I see that relationship shifting. I see this as an opportunity for governments and NGOs to work differently together, because there are things, no matter how much government wants, they are not going to be able to do fully. They are always going to need this other extension. And sometimes I fail to understand why it is so difficult to give resources to these organizations who over the years have proved to themselves that they do fill the gap. Even in the first phase of COVID, we saw how much the NGOs stepped up. You know, they always get to those difficult, hard to reach places even before governments get there. So you are quite right. I really think if we miss this opportunity, both as NGOs and governments, to sit together and have a different conversation, which is NGOs are not always the enemy. The reason governments don't give money to NGOs is they see the NGOs as the enemy, and you cannot give money to someone who is fighting you. That's not always the role of NGOs. NGOs do support governments. They capacitate the communities so that the communities can do part of the work that government can't do. So I think we should really create those platforms of engagement so that these conversations can be put on the table. Because there's not going to be money coming from other countries. They also have their own problems. So we do need to realize that the money needs to come from the country, and it should be distributed through anyone who can assist.
Lois, there was a question about money in the chat, which maybe I'll ask you to respond to online in the Q&A session. But let me turn to Martina. Lucy Kluber asks, you know, in your closing slides, Martina, you talked about the action that we need to engage in, including the urgency of that, and engaging in a research agenda that can help to address some of the stumbling blocks. Lucy, in addition to wanting to know what kind of ketchup I had in my pantry, it's this, Lucy, it's delicious. Martina, I'm wondering what would your number one research question be to help further this agenda?
Thank you, Shafiq and Lucy, for that very difficult question, because I think the remaining questions we have are several, but you can all find them in a research agenda that we have done our best to disseminate, that is out there, hopefully to support that work. But I think there's one thing that I really think we are grappling with, which is integration. I feel like if we put like a long-term vision into what pediatric HIV care needs to be in the future, it's still unclear to many of us working in this field how much we will be able to continue to provide this care through the HIV program, and how much we will be able to integrate, and if so, where and how. And I feel like that is really a research question that requires implementation science. It requires testing out different models and approaches in different settings, because high prevalence countries might be very different to low prevalence settings, and health systems are organized in a different way in different countries. So I feel like this would be a really interesting question that would require testing solutions in multiple places, and that could really inform the way we deliver care in the future. So it's really not an answer that it addresses an immediate gap, but it's really something that can help us to put the longer term vision into the type of care that we need to provide to these children and those that are affected by HIV, even if they're not infected necessarily, which we all know are an important population, right?
Yes, thank you very much for that, Martina. I have a question from Yogan Pillay, which I think is a question for both you and Lois. when we have a COVID vaccine, will it be a problem that currently we're not prioritizing children in the rollout of that vaccine? Do you feel that there are medical, ethical, and human rights implications if we don't prioritize populations of children and adolescents? Do you want to take a crack at that, Martina, and then we'll ask Lois if she wants to chime in?
Nafikiri kwamba kuna matatizo ya tabia mbaya za watoa huduma.
Sorry, we have a problem with the Swahili interpretation. Okay, I think that's fixed. Thank you so much. Martina.
Yeah, so that's obviously a tricky one. I think that certainly the global dialogue right now, it's really highlighting some of those challenges. And I feel like the response will probably be on a country by country basis. And there will be obviously general principles that will inform what countries do, but ultimately it's a country decision. I think that for me, it's, you know, when you speak about human rights and equity, I mean, we grapple with this on children a lot, right? Because sometimes they, you know, because of the numbers or because it's certain diseases not as severe as in other populations, then children are forgotten. And these might well be the case of COVID. And yet, when we talk about universal health coverage and we talk about universal health for everyone, we cannot leave children behind, particularly if they do have a role in the epidemic, also in terms of transmission and so on. So I think, you know, you're raising a sticky point that I think we will really have to address on a case-by-case basis, but the ethical framework to do so is going to be really critical. And I do think that children needs to be equally considered as part of the population, even though based on the information we have so far, and we may learn something new, they might not be the part of the population that is most at risk for severe presentation of COVID. But again, evidence needs to be generated to fully inform that decision, and we can only work with what we have right now.
Thank you, Martina. We have a couple more minutes. Actually, I think we're at time. So Lois, maybe I can give you the last word. One of the slides in the presentation that you gave talked about a young man who committed suicide. His father sort of called on the lockdowns as the reason why his son committed suicide. What is happening in your experience in South Africa that either government or NGOs are doing to mitigate issues of mental health related to COVID in children? Lois, that was a question for you.
Thank you. Yes. Thank you very much. In the what we have seen with COVID, we'll become aware that there are mental health issues connected, particularly to the nouns instituted by governments in their response to COVID, and in an increase in the number of NGOs that are beginning to see health as an issue. I think for me, the challenge is going to be how effective the different emerging people are going to be, because mental health is a very specialized area, and we need to be careful about not doing more harm than good. And when I see everyone now talking about mental health, I get a bit worried, because I don't seem to see the leadership by governments to really provide guidance and the guidelines that are required before everybody can just run around saying that they are now doing mental health. But in terms of responding and awareness, the awareness is now very high that something needs to be done. I think what is lacking is the leadership and the systematic policies and processes that now guide how we embark on mental health, particularly when it concerns children.
Lois, thank you very much. And alas, we have run out of time for this session. I want to thank all of our marvelous speakers, the participants, for their engaged questions. As Luann mentioned in the chat, when we close this session, please go back into the PATA 2020 Summit Hub to select the Africa Cafe session that you want to join, either one or two. So you have a few minutes. Thank you again, all of you, for your engaged conversation. These presentations and the recordings will be made available to you to review. And with that, enjoy the rest of your summit. What a cracking first start to the day.
Thank you.
Thank you, everybody.